Oh, that's a relief. Thank you. Mm. So, yeah, uh, good morning, good evening, everybody. Sorry for this glitches here. So we all know this is a pediatric ECMO that we are going to be discussing all about pediatric ECMO, the indications, and that's what I'm going to cover. And this is the final frontier. We owe everything that we know about ECMO and where ECMO is thanks to Robert Bartlett and the story of the neonate Esperanza, meaning hope. And she was the first mechonym aspiration survivor. So now when we discuss about ECMO, we actually quite vary as pediatricians. Though it started in neonates, as pediatricians and pediatric intensivists, we are a little reluctant, and neonatologists more so in India. Uh, do we ventilate, oscillate, or should we cannulate? And a lot we dilly-dally, and by then there's multi-organ dysfunction, and precious time is lost. We all know it's complex, it's resource intensive, but it is life-saving. And the key is to initiate it early. Now look at this. This is the latest. I've taken it from the ELSO registry. So if you look at neonatal, it's about survival to discharge is about 64%, 72% if it's pure pulmonary. Cardiac for neonatal is about 45%. And ECPR, survival to discharge, is 42% in neonates. Now in pediatric, pulmonary indications about 55, uh, survival to discharge in cardiac is about 62, more, a little more, and ECPR 56, which is fantastic, which means 50% of children who would have otherwise died have actually gone home. And of course, adult numbers are much more, though ECMO started in neonates, the adult team have superseded in numbers. So ECMO for respiratory failure after this H1N1 pandemic, the survival has significantly increased, and it's used a lot more in pediatrics. This is the respiratory runs. This is the 2017 data in India, and a lot has changed since then. So these are for the lung, ECMO indications for lung, and ECMO indications for heart. Uh, and the survival for respiratory ECMO is 40%. This is Indian data. This is in 2017, and 73% if it was cardiac ECMO. But since then, a lot has changed, and survival even for pediatric respiratory has also increased. So what is the key for survival in ECMO? It is the timing before multi-organ dysfunction. So don't wait when you have only 20% chance, because then your mortality is already approaching 80%. So it used to be said, if you think of intubation, you should be intubating. Similarly, if you're thinking of ECMO, you should be reaching out to your ECMO specialist and getting everything ready. And the timing of ECMO, so the number of days on mechanical ventilation prior to your ECMO run is determined by your high ventilatory pressures. So if you have not been on high ventilatory pressures, you can still offer ECMO. And after 14 days, of course, the odds of survival come down. And early ECMO referral is better for better patient prognosis. So transport, this was a child who was put on ECMO in the referral hospital and then shifted to our ECMO center. So the key is early, call the ECMO team, if not in your hospital, at least your referral hospital, and shift before the patient is, crashes during the shifting. So there's no evidence to suggest that prolonged mechanical ventilation is a contraindication before 14 days, but it all depends on your high ventilatory pressures and inter-hospital transport. So ECMO in pediatric population, who should go on and who should not? So these are the basic questions that we usually ask. Is it life-threatening? Is the disease likely reversible? What is the quality of life after you put on ECMO? And what's the prognosis? Is it now unresponsive to all your conventional alternative therapy? Is ECMO more likely to help than hurt? And of course, if sometimes you may have to place the ECMO for cardiac indications even before, stabilize the patient on ECMO and then only take up for any surgery. And then you decide on VA or VB ECMO. These are the basic questions. So general exclusion criteria for ECMO, if there's no chance, because it only delays and does not prevent death, no purpose, It's futile. You're just unnecessarily prolonging life, and there's no quality of life after that. And no ability. You're not able to do ECMO because of practical limitations, and which means ECMO could possibly do more harm. So these are the general exclusion criteria. So respiratory ECMO, I'm just going to briefly touch um, because in pediatrics, a lot of it is respiratory as well. So this is the PALIC2 recommendations, and their guidelines say that ECMO must be considered in children with severe PARDS in whom lung protective ventilatory strategies are failing and respiratory failure is reversible. And there is no strict criteria for selection of children. So it has to be institutionalized, and each institution has their own protocol. Some start a little earlier, and centers who do ECMO regularly, in fact, initiate ECMO much earlier for refractory hypoxemia or refractory shock. So this is the PARDS classification. So those who are adults doing pediatric ECMO and our delegates here, this is the PARDS classification. And you can see there's something called, we all know about oxygenation index. What is oxygenation index? Map into FiO2 by your, what you give by what you get. So what you give is your MAP, that's in the numerator, your pressures times your FiO2 by your SpO2. So the higher you give and the lesser you get, then your OI gets increases. So ECMO is considered when everything fails, and you can see that as your oxygenation index increases, you have ECMO very much there as part of your algorithm in refractory hypoxemia. So the indications for ECMO for refractory hypoxemia, if it's 25, you're already approaching 50% mortality. And if it's OI of 40 to 80% mortality. So now many more centers across the globe are not waiting for an OI of 40. They are starting, in fact, around 25 or at least about 30, because we know as we increase, you're already subjected to ventilator-induced lung injury, and the chances of that lung recovering is much lesser. So OI more than 25 and not improving despite all your ventilator, maximum strategies, with impaired tissue perfusion, rising lactate, need for vasoactive support. So don't just look at one number, look at the patient as a whole and see whether other things are not. If the patient is going into multi-organ dysfunction, start ECMO earlier. Then of course your ADO to PF ratio. Many times we have seen in viral pneumonia, it's the ventilated pressures may not be very high. In fact, they don't even tolerate high ventilated pressures, and the PEEP may be around 8, but they have profound hypoxemia with very low PF ratio. Then, of course, if you have ventilatory pressures high, if it's more than 20-25 MAP, mean airway pressures in conventional, or more than 30 on HFOV. Severe pulmonary hypertension, because what happens when you have pulmonary hypertension, now your heart starts failing. You have hypoxemia with RV, and then which will progress to LV dysfunction as well, and you'll be on so many inotropes. Lack of response to conventional. Also, most important is rate of deterioration, how quickly ECMO can be initiated. Don't wait for the night, because you're not going to get help. So make it more when the patient, it shouldn't be a crash ECMO initiation. Do it when the patient is a lot more stable. Oxygenation saturation index has replaced the PaO2 with SaO2. So this is the OSI in pediatrics, map into FiO2 by your SpO2. So remember that in children it's very hard to get, even in neonates, to get an art line, and you can't keep sampling and following up the patient with a serial arterial gases. So if you have a child who's just transferred to your ICU who's already very hypoxemic, don't wait for just the OI. You can always use this formula to gauge the severity of your ARDS. And if it's OSI more than 20-25, you should be considering ECMO. So this is the oxygen saturation index, so that you don't have to do frequent sampling in neonates when you are monitoring the patient with hypoxemia. So this is an interesting study. What is the OI for ECMO? And this showed that a cutoff of 33 is a cutoff for ECMO, and you should be offering this to the patient. So now another indication for ECMO is hypercarbic respiratory failure. So hypoxemia may not be the only indication for ECMO. Hypercarbia, look at this gas with a PCO to 116, OI was 33, right? The PO2, on the other hand, is about 67, which is not too bad. But the PCO2 was so high, pH is low, the RV will start failing. And so hypercarbic respiratory failure is also another indication for ECMO, your bronchiolitis, your status asthmaticus. And in these patients, many times in asthma, just 3-4 days of ECMO, and you can actually wean off ECMO pretty fast, and it's very, very gratifying. And this is the ventilation index, PCO2 times your high pressures times respiratory rate by 1,000. Anything more than 40 for 4 to 6 hours, you should be considering ECMO. ECMO for air leak allows reduction of airway pressure. So many times what we do for air leak, we even disconnect the ventilator because you don't need positive pressure. Your aim is not to recruit the lungs. Your aim is just to seal the air leak and just allow the lung to totally rest. Remember, try not to put any ICD on ECMO with anticoagulation because you'll only be converting a tension pneumothorax to a hemothorax. So do all these tubes placement before you anticoagulate the patient on ECMO, or at least stop the anticoagulation before for good period, a reasonable duration. Get the ACTs down before you put any drains inside the patient. So the indications for ECMO in pediatrics is expanded foreign body aspirations, hydrocarbon. In India, we see kerosene aspiration, and there the lungs just pop. Pertussis, burns with ARDS, COVID, baby powder inhalation, tracheobronchial trauma, major airway surgeries post-operatively, lung transplantation, rarely, mediastinal mass biopsy, because that's a difficult airway situation. And then, of course, if you want to do extensive bronchoalveolar lavage or any airway surgery, so much so that ECMO is part of the difficult airway algorithm, your ASA algorithm, anesthesia, there's ECMO. So if you have any difficult airway, in fact, if you're going to do tracheoplasty, etc., ECMO, many of these procedures are done on ECMO. Also, mediastinal mass biopsy, etc., or if a patient crashes, a mediastinal mass patient crashes, then of course you should have ECMO standby. Trauma is no longer considered a contraindication for ECMO. Post-traumatic ARDS, head intra-abdominal injuries are not absolute contraindications because you can run the ECMO without anticoagulation. Immune-compromised children, there are now guidelines which actually tell what to do in stem cell transplant patients, ECMO for respiratory failure. So presence of an infection also should not be considered an ECMO contraindication. Neonates, Dr. Sunil has already mentioned, meconium aspiration syndrome, very gratifying. And of course, air leak, respiratory distress, etc. Now, heart failure. So this is like the bread and butter, cardiac surgery, neonatal cardiac surgery, bread and butter of many institutes overseas, ICUs abroad. So ECMO is also there very much in these ICUs for congenital heart defects pre-surgery. There's a separate talk on all this separate different indications. Failure to wean from cardiopulmonary bypass, cardiogenic shock, whatever be the etiology, myocarditis, very gratifying, cardiomyopathy may not be so. Arrhythmias, in children, arrhythmias not so common, but can occur and can be associated because of due to toxins. Myocardial dysfunction, sepsis, dengue. I know one of my colleagues in Hyderabad had a dengue myocarditis. So it was not capillary leak and shock, but had dengue myocarditis, and the child was put on ECMO, VA ECMO, and actually came off. Scrub typhus, toxins, diphtheria, scorpion sting. So scorpion envenomation. So this needs time. So all your catecholamines actually will cause more problems. This is one unique indication for ECMO in our Indian setting. Poisonings, which all can affect your myocardium. Cardiac arrest in hospital, and of course, bridge to heart transplant. So this is, I'm just going through all the different, congenital defects. And if you look, the maximum ECMO runs have been used for arterial switch because there is, myocardial stunning and the heart takes a while to recover, aortic arch repair, your shunt procedure, and pulmonary artery binding. And of course, the other indications are always there, but these are the more common indications where post-operative, post-cardiotomy, you will need ECMO. So this is a very interesting paper by Vivek Gupta, and this is from India, talks about role of ECMO in life-threatening intoxication. And we do see patients, with inadvertent poisonings, pediatric patients so this is a nice approach in his article, which actually says, do you have gas exchange issues? Do you have, hemodynamic instability? Is your inotrope vasopress increasing? What is your 2D echo saying? And then you decide whether you initiate VV ECMO. So the ECMO should be bridge to recovery. In paraquat lung poisoning, which we have seen in some pediatric patients, also a 16-year-old, actually a 25-year-old underwent a lung transplant at our centers, two of them with paraquat lung poisonings, or bridge to RRT. So you put the patient on ECMO, you do fluid removal, toxin removal with plasmapheresis RRT while the patient is on ECMO, and get the toxins out. If the patient, so this is VV ECMO, if the patient has shock, there is or imminent cardiac arrest, then you put the patient on VA ECMO. So this is for intoxication, and it is not at all uncommon to have such a scenario in India. So if you look for indications of in pediatrics and neonates, you have respiratory failure, which could be due to airway issues. It could be due to lung, a bronchopleural fistula, pneumonia, ARDS, inhalation injury, contusion, and then awaiting lung transplant and neonatal respiratory failure. Or you could have cardiac failure indications, failure to wean from bypass, ECPR, cardiac failure due to myocarditis, arrhythmias, pulmonary embolism, not common in the pediatrics and neonates, contusion, myocardial stunning, yes, and of course sepsis, fulminant liver failure, toxic ingestion, etc. Now, what is important when you start ECMO and when you are initiating ECMO for your kids, have this initiation checklist. Keep monitoring so that it's more objective. So any two criteria from the following observed over a period of 4 to 6 hours. So I'm just sharing our unit's criteria checklist. And if you have anything, then you decide whether you have, these are respiratory indications or this is cardiac indication. So cardiac indications, cardiogenic shock with high inotrope requirement, this score of more than 20, rising lactate levels, pH, oliguria, and a low cardiac index. So this is your WIS score. Now, of course, the WIS score also includes your levosimendan, milrinone, methylene blue, etc. So these, you have to have this checklist, and the nurses have to monitor this. And if you have any two criteria, please, you should be talking to your ECMO team and have a multidisciplinary meeting. So you can see that the contraindications are shrinking. Prematurity, low birth weight, bone marrow transplant recipients, trauma are all very relative contraindications, because ECMO can be performed without systemic anticoagulation for short periods till the patient's bleeding is stabilized. So absolute contraindications are, untreatable metastatic malignancy, catastrophic brain injury, or end-stage organ failure without any hope for recovery or transplant. And outcome, younger age, better survival, asthma, viral pneumonia, bronchiolitis, aspirations, and of course, VV ECMO is a lot more easier to manage, whereas cardiac arrest prior to ECMO, severe acidosis, multi-organ dysfunction, duration of ventilation more than 14 days, and multi-organ failure, renal failure, liver injury, all these have a worse outcome. So when you are counseling your patients, your family, it is very important to have objective criteria. So this is, if you look at the ELSO registry, you will get these prognostication scores, pre-prep, rescuers, etc. And if these are available even for neonates and adults. So it helps counseling the families. What are the chances of survival? Now, this is not for patient selection of ECMO. So when you need ECMO, if you need ECMO, you do need ECMO. It just tells you that the chances are this, and it's more objective based on, so you can help, it helps counseling families. Now, cannulation is a separate topic, but just want to tell you that small children, so we talked about cardiac ECMO and we talked about respiratory ECMO, but many times, even for respiratory indications in neonates, in infants, in smaller children, we will need VA ECMO. So it is not for cardiac, it is still for respiratory indications, ARDS, but because the femoral vessels are so small and limit the cannulae size and don't give full ECMO support, So then we do neck VA cannulation for less than 15 kilo. And so this is a meconium aspiration syndrome. It is ARDS, refractory hypoxemia, but this patient still needed, this child needed a VA ECMO and actually was, decannulated and celebrated first birthday. So this is VA ECMO for respiratory indications, and that will be discussed. So the conclusion, ECMO should be a last resort. Early initiation of ECMO improves outcomes. Outcomes are poor if instituted after irreversible ventilator-induced lung injury or multi-organ dysfunction. And coordination with of ECMO centers and non-ECMO centers, this is very essential. And more than centers, it is actually, if you're starting ECMO in your unit, go ahead, very good, you're saving lives, but many times we'll want to have a, ask the expert opinion. So please call Dr. Pranay, Dr. Sunil. You have so many experts around, and ask them, because we have done that, and that's been our learning. And they will really guide you, and that is the key, because you learn. It's not, you won't learn it from textbook. This is just the beginning. Your workshop and what you're going to learn is just the beginning of your journey, ECMO journey, and you will learn a lot with discussions. And as you manage your patients, the team gets better and better. So don't be scared to offer ECMO, but reach out to all the experts when you put your patient on ECMO. Thank you so much. Happy to take any questions.
Thanks, Indira, for the excellent